Okay. Hi, good morning, everyone. My name's Caitlin. I am the current OSU Psychiatry Chair President, and it's my pleasure to introduce you today, Clayton Morris, MD. So our program is underwritten by an educational grant through OSU Medical Center Graduate Medical Education. A disclosure statement has been signed and is on file at the Graduate Medical Education Office. Dr. Clayton Morris graduated from the University of Oklahoma Medical School in 2004 and OU Psychiatry residency in 2008. He then completed a year of training at psychoanalysis with Oklahoma Society for Psychoanalytic Studies in 2009. Dr. Morris started working for the Department of Mental Health and Substance Abuse, covering admissions and inpatient units in 2011, and became the Psychiatry Residency Director at Griffin Memorial Hospital in 2011. He became the medical director of Griffin Memorial Hospital in 2015 and statewide medical director of the Department of Mental Health in 2022. He's worked extensively in the treatment of serious mental health illness, substance use disorders, personality disorders. He also maintains a shrinking psychotherapy private practice. The Cloud CME activity code for today's grand rounds is 1578. Please give a warm welcome to Dr. Clayton Morris.
Good morning. So there is a chat box up there, but I can't see it here. Just in case somebody asks a question via chat. How do I see that? Sorry. I can look that way.
I'm not sure if we can do it except to go.
No, it's okay.
I tell you what, if you want, I can just watch it.
Okay. Yeah. If you'll let me know when there's a question or something like that, that would be great.
That's what we'll do. Okay. All right, you're in presentation mode.
Okay.
You good then?
Yeah. So I just, yeah. How do I?
There is a clicker though, right there.
Oh, there is. Okay. Good morning. Let me see if I can advance or not advance. Ha. It's not advancing up there though.
Yep, that actually worked earlier. You may have to just use this one then. You may have to just use this
Okay,
one.
let's see. Well, so
Yeah,
did that advance it on there? No,
it should.
it did not.
Well, darn it.
Good morning. While we're waiting, I'll tell you I have no financial disclosures. I actually don't even talk to farm reps. I'm pretty rude to them, medium rude. Maybe more clearly define it as oblivious.
Okay, I don't know why it's not doing it now. Okay,
That looks like it may be working.
I think it'll work now. Okay,
Aha,
all right.
we're in business. So we're going to talk about violence in healthcare today, which is a pretty big deal. And I'll talk a little bit. It's underreported. A lot of people think that they just have to tolerate this, and I disagree. There's a lot of feelings about shame involved in dealing with it, and doubt, especially I think culturally that may be more widespread than just medicine. Also, I'd like to point out that healthcare workers have their own trauma history. When we do the ACE, which is the Adverse Childhood Inventory of experiences for kids, when we do those on just general population, we see pretty big numbers everywhere. When we do it at Griffin, we are only slightly less traumatized than patients, which makes sense. I think we're drawn to that sort of work for reasons. My wife had to do an ACE as a teacher, and all of the teachers had to do them. And there was some pretty shocking discoveries that they had to kind of self-explore, but they were trying to work in trauma with kids, and understanding your own trauma is one of the backbones of dealing with that. And then what do you call violence? So throwing an object at somebody count? How about verbal threats? What about blocking somebody's exit? What do you think? Yeah, all of those count. Every last one of those count. these are the things that I ask spouses about the relationships or domestic partner relationship. These are the things that I ask about when I'm looking forward. Yeah.
I can't hear you in here.
They can't hear me.
Yeah.
In this room, they can't hear me.
Yes, correct.
Well, I
in
can
here.
talk louder.
Okay, let's see. Not sure how you make that go up. Maybe it's this one, the one above. Okay, can you get that one?
Yeah. How about now?
Yeah.
Any better? It didn't look like a lot of yes.
Yeah. Okay.
I think it's just slow.
Okay. Very slow.
Hello. Do we just get closer to it? Yes. Be closer friends with your microphone. Check. How about now? Is that better? Okay. Well, you're going to constrain me to one position. That is not an easy thing to do. All right. The impact. Of course, there's physical damage, psychological damage, reduced job performance. Almost everybody that encounters something like this has a sequela of some sort or another. Burnout. Reluctance to be close to people, especially patients. Reluctance to take on a difficult case. You know, I hear in what I do for a living in psychiatry, a lot of people say, "Oh, I don't deal with personality disorder." Some of these are reasons why people don't want to take on those. And then, you know, your own self-esteem. So here's some just numbers that I pulled. It's pretty common, really. We're going to skip through some of this because I don't want to run out of time for the stuff that actually matters. It's really common. Okay, moving on. So let's talk about an approach. Number one, if things are already violent, your approach is to exit in general. I don't advise you being a hero at any point in life. There are other sorts of people that handle violent patients. I don't think it should necessarily be you. With that said, I often intervene on violent patients. I do this for a living. I am very experienced with it. So, and I know kind of what my limits are, but in general, I wouldn't advise that for you. So assess your danger. Today, we're going to talk about this approach, but it's mostly in the cognitive sphere. I'm going to tell you some things to hopefully increase your awareness and thinking. But there, in the world of psychoanalysis, there are three legs to the stool on which you perform, right? One is your cognitive ability, your theory, your understanding of patients cognitively. But the other two are your internal constructs, your own affective makeup. How do you deal with people that are angry, for example? How does that affect you internally? What does that make you say? That's an internal construct, right? And then just your experience this is the third leg. How many patients have you seen? How many times have you had success? What kind of supervision have you had working with that? So we're going to talk about the cognitive sphere, but I just wanted to point out there's more to this than just kind of understanding in that sphere. Oh, I'm also going to say this from the physician perspective, but I'd like to remind you that all of your staff have these same interactions with patients and the same difficulties that you will have, only with less authority than you. And I'm pointing that out because there's going to be something we're going to call the fourth position here in just a minute that I want you to understand. You cannot, as a physician, be in the fourth position of the trauma triangle. Okay, we'll get to that in a second, though. Two types of violent people. I'm going to break this. This is an enormous simplification, but I want to break it into something understandable. There's two types. There's the psychotic and what I'm going to call shame-based. Most of what you're going to encounter is actually shame-based. We're going to talk about psychotic here briefly, but most of what you're going to encounter is shame-based. We often say something about violence after it happens. Oh, that person must have been crazy. Usually they're not, actually quite human. When we get into what is like to be shamed, one of the reactions to shame is violence. And that is a very human experience. The psychotic, also human experience, by the way, but one that we're less in touch with is a bit different. I also wanted to point out that all of you have a psychotic piece. You may not want to acknowledge that, but it is there. The more we acknowledge that, the more comfortable we can become working with people that have psychotic elements. I'll give you an example. So Bion said about psychosis that it's a semi-permeable membrane between this unconscious psychotic self and the conscious, what we think of as rational self. Some people have bigger pores in that membrane. And he said, in day-to-day function, those people are creative. They look at a piece of stone and can see what could be made from it in carving it, right? That is a psychotic process. If you don't have access to that, you go to a play and it seems dumb that people are pretending to be someone they're not. If you do have it, you can get lost in characters and story. That is part of the function of psychosis, right? Psychotic violence is almost always anxiety-based. They are scared of something, terrified of something. That something is often you. This is the easy one, by the way. We're going to go through the easy one first. What do you do when somebody's terrified of something? Well, I remove it as best I can. I step back. I listen to what they say. They say something in a psychotic voice that sounds like, you must be of the FBI. Well, I'm not, but that doesn't matter. They are telling me they are scared of me. So what do? I back up. I sit down. I remove myself as a threat. I remove other things from the threat, as a threat. I get other staff to back away, and we make the environment as calm as we can. I will literally put my hand in front of a staff member and guide them away from a psychotic patient. I will say, why don't you stand over here? You look menacing. Oftentimes that's like a security guard because their job is to look menacing. At least they think that's their job. Back them up. This is very simple, right? How do you know when somebody's fearful like that? I feel it. So we're going to talk about paying attention to your feelings in a minute, but it's true of this patient population as well. I feel it. And I listen to that feeling and I back people up and I give them space. Sometimes I will let them leave. Like if you're in the emergency department, let's say they come in with some sort of major injury, they want to leave. You know what I do? I let them leave. It's okay. And they'll probably come back if they calm down. It's all right. What do you do in the world of psychiatry? Well, I can't always let them leave. Sometimes I say, can we talk? And then decide what happens. Sometimes that works. Sometimes it doesn't. Okay. That's psychotic violence. That's the easy one. The rest of the talk, it's about the hard one. Oh, I wanted to say one more thing. You see somebody that's violent and psychotic, please treat that or have somebody, referred to treat that. It does need to be cared for. It will come back oftentimes. I point out that we have 3-month and 6-month long-acting medications for these things. I do quite a bit of forensic work. This is a mainstay of our treatment. Long-acting antipsychotics are super helpful. I put on their psychotherapy. We do psychotherapy with people that have psychotic illnesses as well. All right, now the hard stuff. I want to pay attention to time too. It's okay. All right, we're doing all right. So we're going to talk about shame enactments, which is really working with people that have personality disorders. I call this personality constructs because all of us have personality issues. It's mostly common in the cluster B. And I'd like you to remember that these people have attachment disorders and emotional regulation problems. And if you think about that going into it, this will make a lot more sense. And we're going to work on how to avoid the most common entanglements that I see. And I'm going to use residents as an example in and out of this talk, because I see this happen, especially with my 1s, but also with my 2s and some of my 3s. So here's rule number 1. Don't take this too personally. It's mostly not about you. When somebody comes at you angry, even saying really awful things to you, it's not really about you. Mostly. I put the word "to" in there for a reason, because sometimes it is a little bit about you. The patient comes in, I'll give you an example of a non-violent interaction. Patient comes into my office and says, this actually happened to me, but patient says, "Your furniture is a cheap knockoff," and she named some famous furniture designer. It's a cheap knockoff. What do you say to that? Well, if I'm non-defensive, I don't have to defend that at all. It is a cheap knockoff. I'm actually kind of proud that I buy cheap things. I was raised frugally. This is not an insult to me. But if I listen in that and don't take offense to that in any way, I can hear something in that, which is maybe something is not right with our relationship, right? Maybe she's saying things are not real between us, which is a real criticism of me, maybe, right? So if I don't get defensive, then I can start to hear things that patients say. It is a little bit about you. Okay. That one's pretty easy, but it's really not. I see residents be defensive all the time. I'll give you an example. Let's go back to one. We're not done with one. Here's a common resident challenge. I've already answered all your stupid questions to someone else. Why should I talk to you? Anybody got an answer? So if you're going to be defensive, you're going to give reasons why they should answer such questions, right? Well, I'm the doctor. Don't you know? Can't you see my badge? That's defensive, unnecessary. What can we do instead? Oh, you didn't realize this was going to be audience participation. Oh, no. Those people that sit in the front row. Yeah, I still think that's giving them a reason. Like, let's go back to validating them first, right? That's pretty good. It's a little better than I'm a doctor for sure. But let's go back to validating them. I hear you don't want to talk about this. I think I can understand that. It sucks to come in and tell your story over and over and over. And then maybe I'll just be quiet. This is the kind of stuff that usually works for me. Let the patient have their moment. There's no hurry here. We're going to talk about letting go of your agenda here in a minute. Okay, rule number 2. Be a helper and not a savior. Why'd you come into medicine? Most of us came for the idea that we would have power over illness. And in a way you do. There's a trap in that, though, for a psychiatric patient. And we're going to talk about that trap. And it's called the trauma triangle. Now, there are only 3 positions on this, but there are actually 4. We're going to talk about a 4th one here in a minute. So the 3 positions of the trauma triangle are persecutor, rescuer, and victim. Yeah. Where do you want to come in as the physician? It's rescuer, of course. Nobody wants to be persecutor or victim. That sounds awful. What's the trap on being a rescuer? Well, I don't rescue people. That's really not what I do. There's no fixing of what is wrong with somebody who's traumatized. There's no fixing that. I cannot go into the past and delete those events. What can I do? Well, I can help them with it. But if I have the fantasy that I can fix this, and we're going to go through, all of you have this fantasy. This is a trap that all of us fall into. Then you're going to get in trouble. Because when you hold on to one position, then you're going to be forced into another position. I'll give you an example. Somebody comes in. I had a patient that I saw that was very somatic. She came in with chronic pelvic pain, chronic abdominal pain were her 2 biggest, although she had others. You got any ideas about what sorts of treatments she received before she saw me? Long pause. Any guesses? Oh, I know you're thinking something. Well, she had a lot of surgeries. One of them was a hysterectomy on a 20-something-year-old woman, which, by the way, she agreed to. She understood the risks of that. Did it help? No, it did not. Did it hurt her? Yeah, it did. She didn't have any kids. It's one of the things we processed. So which position, you started off in rescuer, which position did you end up in? Persecutor, right? You hurt her unintentionally. People gave her pain meds thinking that they would be helpful. Did it help? No, it did not. So now you're in that position of persecutor. And this is where your anger starts to build in patients when we have these sorts of interactions. What did we need to do? We needed to face our own powerlessness and say, I'm sorry, I can't fix your pain in that way. Which, by the way, would probably make her angry. Of course, she got angry. So what can we do? We go back to rule number 1. You don't take it personally. Just because you can't fix this doesn't mean that the patient's anger is really about you. She was mad that she had chronic pain, which was trauma derived. She was mad that somebody hurt her. That is not your fault, right? If we can think about it like that, then I think it's easier to let it go and easier to stay out of these interactions. Let's see here. Here's one that a lot of psychiatrists, you've got to get my son or daughter off of drugs. You need to put them into the hospital, keep them there until they're sober forever. I don't have that sort of power. Yeah, they'll be sober theoretically while they're on my unit. I don't admit people for drug and alcohol problems unless they ask for my help, ever. I don't do it. Why would I? It's forcing something on them, right? Yeah, they're killing themselves with a substance. Yes, I understand that. The only way out of this is for them to choose to be well. If I force them, I'm right back in this thing. And that's how you get to shame enactments and anger and violence. So this is how the anger starts, right? So you do something that actually hurts the patient then attacks you. Here's another way. A lawsuit is a pretty painful way of a patient attacking you. Do you have to be guilty of anything to be sued? No, you do not. I've never been sued, thankfully, but psychiatrists are kind of hard to sue. Here's a common patient. You feel the patient's anger, and so you don't call them back. They leave you 30 messages to your receptionist, and so you choose not to call them back. That is avoiding something, and we're going to talk about that. And that is the 4th position, which is, well, I don't put it on here. There's a 4th position in this, which is the observer. And the silent observer does nothing. And I see this happen a lot on units where a patient fight breaks out and one staff member will be completely ignoring it. Why do they do that? Well, it's an intense interaction. They have their own trauma history. We feel uncomfortable with interacting with that sort of rage and anger. As physicians, I think one of our tasks is to step through that and try to deal with whatever is going on in that moment. And if we go back to rule number 1 and don't take this personally, then we can approach this in a non-judgmental and non-authoritative stance. Okay. All right. Why do people do this? Well, Freud said this was the repetition compulsion. You grow up traumatized. You see the world as full of trauma. You interact as if it will be, and it is. You create it to happen. If you think someone is going to be violent with you, I mean, you'll see this sometimes in social situations that get kind of hairy. Somebody says something kind of not nice, then the intensity increases. We all say things that are not nice. If you have a trauma history, you're expecting that to then become violent. And so you start to prepare for violence. If the other person has a trauma history, they start to prepare for violence. It doesn't take very long for that to go in a really terrible way. When I walk into a unit, I start to look around for those sorts of interactions. What is bubbling up? And I start to think about what sorts of things can we do? Do I need to physically separate people? Do I need to draw attention away from an interaction? Do I need to have the patient tell me something about why they're angry? These are things that I do. So the two theories: it's defensive to believe that the world's uncaring. If you grew up with the world uncaring, it's easier to think that the entirety of the world is uncaring than to think about it as only your world is uncaring. That's a defensive structure, so that when, as physicians, you offer caring, they don't accept it because they don't think it's real, or they don't think they're deserving. That's the other one. I'm the problem. And the defense becomes about me. I am a terrible human being, and that's why all of this happens to me. The problem with these defensive structures is to keep them defensive, you must make them real. And that's where you'll get people rejecting your help or rejecting that. What do you do when a patient rejects your help? Most of you try harder. Give them more. Here's some more. I just attended a statewide meeting about a really difficult patient. Sometimes we do those. And my thought was, the patient didn't want our help. So nothing that we can do. And all of these, there's about 15 people in this Zoom meeting. They were all trying to think about how to save this patient. And my point in the meeting, which is not popular, by the way, was I don't think the patient wants any help. We should probably deal with that first. What do you do when somebody doesn't want your help? I start talking about it. It doesn't seem like it goes very well when you're offered something. We're only to 2B. Let go of your agenda. Whatever your agenda is. If it's not going well, just like offering help in my example, let go of your agenda. I see this in interns. They want to get done with their initial interview. That's their goal. Get done, get orders written, get the patient admitted, move on to the next patient. That is their agenda. And I get it. Call nights are long. There are lots of patients to see. But if the interview is not going well, give up. Recenter on what does this patient want from me right now? What do they need from me? So I just ask. I say, doesn't seem like this is going really well. What can you tell me about it? And they'll say something like, you're going to keep me here against my will. And I am always honest with patients, by the way. I do not lie to a patient ever. It gets you in a lot of trouble. And I'll say something like, that could happen, but only if I'm really scared about how dangerous you are. So now we have a potential contract between us and them. They know more about what I'm going to do. I often also approach with the parameters in mind. I tell patients exactly what I'm thinking. I'll say, I need to screen you for a number of things to see if you're safe. It's going to take about 45 minutes. Again, completely transparent. I don't want there to be guesswork around what I do. I'm going to ask you some personal questions. You have the right to decline to answer any of them. It does not matter to me. I just am interested in this. And I think some of them will have impact on your care. But you have the right to say no. If there's something that's bothering you, please let me know. Transparent with my approach. Number 3, this could really easily be number 1, but I just wanted to make sure that you didn't approach defensive. So I put the number 1 as don't take it too personally. Affect is everything to me. Every decision I make is based on how things feel with a patient. You think that it's all cognitive. There are lots of cognitions going on, but it is all based in affect. Everything I do, the resident will say to me, how did you know what to say to that patient? I had no idea what I was going to say to that patient. I felt like that was the right thing to say. How do you know when to validate? When it feels like the patient needs to be validated. How do I know when to be quiet and listen? When I feel like the patient needs me to be quiet and listen. How do you get good at that? Well, that's a little bit of practice, but what I will say is that most of you have this ability right now, if you will let go of your agenda and pay attention to how things feel with a patient. How does this feel? So Gordon Decker used to hammer us on this, and he would say, Morris, did you do your daily inventory? He would say that to me, which is take stock of your own feelings before you meet with a patient. How am I approaching the patient? Am I already anxious? Am I angry about something else? Pay attention to how things feel. Know the difference between their feelings and your feelings. It's actually pretty hard. Human beings are wired socially, and one of the ways that we detect another person's feeling states is how we feel internally. We can easily confuse that with our own feelings. How do I know the difference? I pause and I ask myself that question. Is this me or is this them? Did I start the interview with this feeling? Because then if so, it's probably me. Did the patient say something that triggered something in me? Maybe. But most of the time, I feel something strongly, even though it feels like a very personal feeling to me. It's not about me. Almost always. It's about the patient. If I can listen to that, I'm hearing something. If I start to feel anxious in an interview, there's a reason. I should ask myself, what is that? How are we doing so far? We're like halfway through this thing. We doing all right? Yeah. Any questions so far? I should say that I'm open to questions at any time. Mostly in my work, I don't do the talking. I do the listening. So I'm plenty happy to do both. No questions. Okay. Any chat questions? No. Okay. Rule number 4. Watch your frame. What's the frame? The frame are the way that you approach the patient, all your internal rules, all your external rules. How do I normally operate? If I see myself deviating from my normal operation, that should signal to me something is up. Am I spending extra time with this patient? Am I spending less time with this patient? Did I answer more phone calls after hours for them? Did I make special provisions to make sure that they were cared for? None of this is wrong. Forget about the world of right and wrong for a bit. It should make you ask the question, what is going on? And am I caught back in rescuer? That's the question that most of you should ask yourselves. Am I trying to rescue this patient? And if so, from what? If you think the answer to that might be yes, then we think, why? Is this patient not actually listening to me? Is this patient super dependent upon my need, on my giving? For violence, where do you notice the frame violations? Usually it's in restriction, not extra giving. It's this patient is not a very nice person. I don't want to give to them. That is the beginning of an enactment. You've now neglected them and they are going to be angry about it. You're going to tell yourself it's because they're not very nice. How do we process that? Well, if they're not being very nice, I start saying things about it. Instead of restricting what I have to give, I process that with them. You seem upset. You seem angry. You seem like you're not getting enough from me. These are all questions. It doesn't mean I do anything different. I may not give anything different, but I do process it. Number 5. So we talked about the rules, watching your frame. Number 5 is sometimes you break those rules. Because being too rigid is another way into an enactment, just like being too loose with your rules is. And I say that just to point that out. Sometimes you do break the rules for the patient for a good reason. Sometimes you pay a price for breaking those rules. How do you know when to break the rules? You don't. You have to really think about it. And sometimes, this is medicine, it's often an art more than it is a science. I try. And if it doesn't go well, I learn. This patient doesn't do well when I step outside of the rules a little bit. How much physical contact do you make with patients? So I'm a psychiatrist, by the way, and my world is different than yours. But I bring that up because I make zero contact with patients, like zero. If I do it, it's like a handshake and I still don't love it. Part of that's about me, but I don't touch them. because I deal with traumatized people and I do not know how touch is going to affect them. I don't know. And you might think that it's warm and friendly, and on your end, it might be, but on theirs, it is not. They feel threatened by it. They feel overwhelmed by it. Now, as doctors of physical medicine, you don't have a choice, but you can talk about it first. How do you know when to talk about it? Because some people, if you didn't grow up with trauma, then going to the doctor and being touched is not that big of a deal. Like without much preamble, the doc can say, I'm going to examine you and you're okay with it. It's fine. It's reasonable and normal. If you have a trauma history, how do you know? Back to rule number 3. I feel the patient's anxiety. And so you should ask yourself, why am I anxious? Okay. The patient's feeling something about the impending exam. So you just talk about it. Hey, I noticed that maybe this is making you nervous. Is there something I can do to help with that? You'll be surprised. It's just acknowledging somebody's anxiety, how much that decreases the problem. Has anybody ever had a patient get angry after they were touched? I want to bet it's happened to at least one of you. Part of that may be nothing to do with what you did or didn't do, except for you didn't notice that they had a trauma history and it evoked memories for them. Rule number 6, avoid authority battles or contests of power. Why? Because this population cannot tell the difference between surrender and submission. What's the difference between those two things? I surrender because I'm surrounded by the police. There's nothing to do here but for me to put up my hands. It doesn't feel like I have to do anything about my ego involved. This is the right thing to do. My hands are up. I'm making myself non-threatening. It doesn't feel like a shame enactment to me. So submission is different. It feels like I have to become a lesser person. That is a different interaction. These folks do not know the difference. And so how do I avoid that? I just don't get into authority battles. When I was a second-year resident, I remember one of the nurses called me, this patient needs an immediate IM, they're violent. Can you give me Haldol for them? And I said, well, what happened? Well, she got violent. Yeah, I heard that. What happened before? Well, she got mad. Oh yeah, why? Tell me more. She was mad that I didn't let her have her teddy bear. So this is a violent fight about a teddy bear, is that right? Yes, it is. I said, well, why can't she have her teddy bear? It's against the rules. What rules? Again, I didn't see that posted anywhere. It's against the rules, Dr. Morris. I don't know it's against the rules. Well, it might have drugs in it. Could have weapons hidden inside this teddy bear. I was like, okay. Can we check teddy bear for weapons and drugs? Can we do that? Yeah, we can. Why does she need a teddy bear? The nurse was mad, not that the patient wasn't afraid that the patient had some sort of weapon in there. The nurse was mad about the patient's dependency and was fighting against the patient's dependency by not giving her a teddy bear. Why get into such a battle with somebody? Give her the teddy bear. When do you need to enforce rules? Well, when it's about safety, real safety, but that should be a real soft approach. So somebody comes in, let's say they're in an unauthorized area, for example, and they're not supposed to be there. Instead of telling them to get out, I usually ask a question. It's something like, do you need something back here? You'll be surprised at the answers. Do I eventually kick somebody out? Yeah, of course. But I do it gently and I do it with their ego in mind. I don't want to be the authority or the power, almost never. And, I'm the medical director of the hospital, so I am the authority. But I don't think you need to wield it, not much. Mostly I talk people into doing, I ask them, would you please mind leaving? This is an area where patient information is located. And, because of that, we worry that somebody might see something that they shouldn't. I give them a reason. That doesn't always work. None of this always works. I'm just trying to give you ideas of how to avoid fights with people. Eventually, you might need to call security. Certainly, if it felt dangerous, back to rule number 3, if it feels dangerous, you shouldn't be interacting. But most of the time, it's not. Most of the time, it's us that created the problem because we were too brutal with our authority. They can't tell the difference between surrender and submission. I'll tell one more story. So one of the third-year residents a number of years back called me and she said, I don't know what's happening with my patient. I said, well, tell me more. She said, well, he was arrested for destroying a Taco Bell. And it's not like him. He's not usually such a thing. And I said, well, did you talk to him about it? No, I haven't. So, okay, that's the next step, right? Why did he destroy the Taco Bell? Well, when he was in the Taco Bell, they gave him a bean burrito and he didn't order a bean burrito. And it made him so mad that they gave him a bean burrito. That sounds dumb, right? Why did you know, it's like a 17-year-old behind the counter that screwed up your order, whatever, right? Those of us without trauma backgrounds, that's no big deal. It's just throw the bean burrito away. I don't even like correct them, like whatever, done. Or I'll eat the bean burrito. Why did he react like that? Well, when he was a child, he was forced to eat his own feces. I just wanted to point that out because that is a trauma enactment, right? And it's seemingly unnoticeable by us that don't live in that world, because why would you get mad about this bean burrito? Why would you throw a big fit about a bean burrito? There's a good reason, a really good reason. You just don't know it. And so when I hear about somebody's reaction to something that doesn't make sense, I start thinking it has to make sense somewhere. And so my job is to ask the questions, right? Now, you're not a psychiatrist necessarily. Maybe your job is not to ask the questions, but I would like you to understand that there is a good reason for this. And if we can understand that about patients, then this whole approach can make a lot more sense to you. It's a very graphic story, but I did want to hammer the point home. Sorry about that. Okay, rule number 7 of 28, by the way, we've got to move. I'm kidding, there's only 8. Set your limits without moralisms. When you say something is bad, it is very easily to interpret that as you are bad, as from the patient's standpoint, right? So I'll give you an example. Drug use. When you say that's bad for you, you're doing something bad. Does that ever work, by the way? Hey, heroin's bad for you? Oh, really, doc? I did not know such a thing. Even smoking's bad for you. Does anybody smoke? Don't answer that. Vaping, scourge. Actually, I like vaping better than smoking. Not personally. I just like that patients do it. It doesn't stink as bad to me. That's just a personal preference. Does it help telling them it's bad? I don't think so. In general, I set a limit. Like let's say I'm dealing with somebody who's antisocial. Instead of saying, you need to follow the rules because you're bad if you don't, is the understated thing, right? You're not being very nice. What I say I say it like this. I say, it's real hard for me to let you go when you throw things at people. It's hard for me to make the justification that it's safe to let you go. I'm not saying they're bad. I'm just saying, if you want to accomplish a goal, then let's move towards it together, right? What do you think? Can we do that? Yeah. All right. Number 8. What to do when things fail, because invariably things are going to fail. Number 1, talk it out. Find somebody that you trust, present the case. This is what happened. They'll tell you what went wrong, almost always. But Morris, you know that this type of patient, you always do this. Okay, thank you for reminding me. I don't know how many times I present the case to somebody and know the answer before I'm done presenting. Like I'll feel the enactment because I bring it to cognition, things that we deny ourselves when we are forced to talk it out. we bring those into our awareness. Also, Owen Rennick says, turn all your cards over when things aren't working. Don't hold anything back. You say, this is what I know about you to the patient. These are all the things I know. And the patient will correct you because you've got something wrong. Invariably, that's the problem. You don't have something right. And they will correct you. And then you can say, oh, thanks for telling me. Ask yourself, are there any judgments in me? Because that is bound to destroy your relationship with somebody. If you judge them, people feel that from a mile away. If you have judgment, and you're going to think you don't, but everybody does. So ask yourself, is there a judgment of this? And why do I have that judgment? Can I let that go? If not, probably they need to see somebody else. But most of the time, your judgments are about something in the interaction between you and them, and you're being defensive in some way, shape, or form. Okay. When am I supposed to be done? Like nowish? I can be done anytime, but a few more minutes. Okay. Let's talk about shame versus guilt. We've been talking about shame. I've been mentioning shame, but I just want to really bring home the idea of shame versus guilt. So what is the difference? Guilt is I've done something bad. I have wronged someone. I have done this wrong thing. I should make up for it. What is shame? Shame is I am something bad. There's no one doing that one. Why do I point out the difference? Because when you see these interactions with patients, when they have these, like when you're dealing with a real narcissist, on the inside of a narcissist is a pool of shame, of very difficult moments. Anytime they're vulnerable, they feel ashamed because they do not like the idea of needing anything. And so when you tap into vulnerability, this is like the old saying is like, for a psychiatrist working with a narcissist, if you thought the session went really well, they hated it. It was terrible for them because they were vulnerable. We like vulnerability. They do not. And so when you're dealing with somebody who's in the narcissistic or antisocial spectrum, I am less obviously kind. You cannot out nice this. So what I do is I walk in, I say, I'll give you an example. So I was working at the VA, and a buddy of mine who was in the ER said, can you please help me? We have a really rough patient. I said, yeah, whatever. Okay. Not like I'm doing anything else. No, I was busy, but I came down and the dude had torn up the ER. Like there was stuff everywhere. And so I didn't come in and say, oh, sir, how can I help you? I didn't do any of that because I felt his narcissism from a mile away. What I came in and said was, you are a feng shui master. I love what you've done with the place. Can you decorate my house too, just like this? And he laughed. And I knew we were okay at that moment. I said, you're in a bit of trouble. I'm going to sit over here. If you want to talk to me, fine. If you don't, I don't care. Is that nice? Doesn't sound nice, but I was offering something. And that is a deep understanding of shame. Because if I come in and either try to take control of this for him, or if I am too nice, it won't go well. And so I just don't. How do you know when to do that? Well, that's a bit of practice. I just wanted to point that out. Because a lot of your most difficult patients are either going to be in the borderline or narcissistic spectrum. Watch out for the antisocials. By the way, I think of narcissism and antisocial being the same, just farther along the spectrum. If the farther out you go, the more antisocial you are. How do you deal with that? It's not by being nice. I keep all my kindness on the inside. I just interact with them in a way that I think is superficially okay, but not super effusive, if that makes sense. Okay. So again, this is a cognitive exercise to help give you some ideas of how to avoid the most common entanglements I see. I have another talk in April, so I would like your opinion on what you want next. So I'm hoping to bring in an experiential version of this. I'd like to have some video. I'm trying to get video from the unit of both interactions with patients that go well and those that do not. We have a lot that don't. Turns out we pay attention a lot to the ones that don't go well compared to the ones that do. So I'd like to bring in some things for you to watch and see what I'm talking about. I'd also be interested in your cases. If anybody was interested in bringing a case for me to present, I think I'd be really interested in talking about how we ended up in a not great place. I do this with residents all the time. I had an attending that got hit the other day, and we processed how he ended up there, which is interesting because he's like 6'4", 280. You wouldn't think anyone would punch him, but somebody did. It's an interesting thing to have happen, right? It had to do with his own aggression, and he did not like the patient. Anyway, that's the whole story. So that's my email. Feel free to contact me. Other questions that I can answer for you? Let me show here. I can't see that. Okay, well, thank you for your time. I appreciate all of you. It's just that 1578. Yeah. Oh, I know you don't like handshakes, but you know, so like fiction interaction. Yeah.